Right, it's 5 past the hour, so I think we best get started. So, thank you for all coming, fresh and early this morning. My name's Mark Pallen. I'm a professor of microbial genomics here at the University of Warwick, but I'm a medical microbiologist by training, although I'm now a full-time academic, so I'm not actually in clinical practice. And I'm going to take you through respiratory tract infections this morning in the next hour, although we probably won't take the full hour to get through this. You've been taught by Esther Robinson, but she's now left. She's passed me on some of her slides. I've adapted them for my own uses. And I also have to give a hat tip to Wikimedia, because I've stolen lots of images from Wikimedia, and I haven't had time to go through and attribute each one of them individually, but they're all released under Creative Commons anyhow. The other thing I should say is that I'm making a recording of this of my own, and it's being recorded officially. I put all of my lectures and seminars up on my YouTube channel, and if you're interested, you can go and listen to the whole lecture again, or you can go and get it off YouTube and strip out the audio and listen to it while you're jogging or in the bath or whatever at a future date. And for those of you who are not here watching this on YouTube, it's a bit like, hello to all the viewers on Dave. Right, so the learning outcomes are to define the various terms associated with respiratory tract infection. I've included some material on upper respiratory tract infections as well as lower respiratory tract infections here. You've got to describe the common syndromes, list the common organisms, and apply some of the principles of microbiological diagnosis to respiratory tract infection, and apply the principles of management of infection to respiratory tract infection. There should be a 2 there that's missing. Now, I'm aware when I give lectures to undergraduates and to medical students that there's always this issue about, hang on, you're giving us far too much, all these bloody links you're giving us and stuff like that. And some people freak out, say, oh, it's far too much. Now, if you feel like that, then rest assured that the tip of the iceberg is this talk and these slides. And if you memorize all that, you will pass your exams. What I'm hoping, though, is that some of you have already got the idea that medicine is actually evidence-based, and we don't just say a thing that comes into our head because it feels like the right thing. Every piece of advice we give has to be based on this great iceberg of knowledge, of evidence that comes from clinical trials, and so I've not been. I'm not apologetic for sprinkling links to the definitive sources of information and guidance as we go through. But the point is that you're not expected to read all of those documents. Some of those documents have 10, 20 pages. You're not expected to read all that. It's just that you know it's there, and you can skim read the summaries. And as I mentioned before, this talk's going onto YouTube, and I've put some... there's other material of mine on microbiology on YouTube. If any of you feel that you're a bit at sea and you don't know the basics of how microbiology works, then you can look at that. So in terms of the global burden of respiratory tract infections, it's clear that we are dealing with a serious issue here. There are more childhood deaths from pneumonia than from any other single illness. Okay, in the UK, we're talking about relatively low incidences, but when we talk about cases throughout the world, we're talking getting on for 500 million cases per annum and 4 million deaths. This graphic here shows, it's taken from the WHO, showing the top leading causes of death a few years ago in 2012. And you can see that lower respiratory tract infections are up there at number 4. And COPD is at number 3, but obviously COPD is usually complicated and by infection, as we'll see later, by exacerbations that are due to infection as well. So it's clear that infections of the respiratory tract play a major role in the fate of humanity across the globe. Now, going from that global picture and immense importance, let's go to something much more commonplace, the common cold as our starting point. This is caused by a range of viruses, most commonly by what we call rhinoviruses. The rhino part is from the Greek for nose, and these are viruses that affect primarily the nose. There are other viruses also sometimes seen, coronaviruses typically, but there's a whole range of other viruses that can give you a snuffly kind of cold-like syndrome. Thing is that we often don't know what the cause is because we don't investigate the microbiology of the common cold because it is self-limiting. And you've all had this, the rhinorrhea, sore throat, sneezing, cough. And the thing is that this is self-limiting. It does not need treatment with antibiotics, and this is one of the major issues that you'll face in primary care of actually persuading patients that they don't need any antibiotics for their common cold. One issue also is that you do give supportive management. You can give antipyretics like paracetamol and aspirin, but you have to avoid aspirin in children because they are at risk of this particularly nasty syndrome, Ray's syndrome. Although very rare, it is a recognised complication. Okay, what about sore throats? Well, sore throat consists of inflammation of the pharynx, pharyngitis, together with, but not always accompanied by inflammation of the tonsils. And again, as with the cold, this is mostly viral. And we do not need, therefore, to use antibiotics for the majority of these cases. But there is one important common bacterial cause, and that's Streptococcus pyogenes. Now, it's slightly confusing. The nomenclature part of, as you must be aware, that part of mastering medicine is mastering the jargon. And we microbiologists have another name for Streptococcus pyogenes. We call this the group A beta hemolytic streptococcus. And that's because of certain characteristics I'll explain in a moment. And that's sometimes abbreviated as well to an acronym there. There are less common causes of a simple sore throat, and some of these we'll mention in more detail in a few more slides' time. But Streptococcus pyogenes is the one that's perhaps most important. And this does create a dilemma in the primary care setting of when do you actually treat. And there are these so-called 4 centaur criteria that are commonly recommended now as a way of working out whether you should give antibiotics. So if there's a tonsillar exudate, so you can see in this image here, you've got this exudate on the tonsils. If there is lymphadenopathy or lymphadenitis, particularly the anterior cervical lymph nodes, the tonsillar lymph node down here, and history of fever, and if there is a sore throat but no particular cough. So having 3 or 4 out of those suggests that, yeah, you should give antibiotics. If the score is 0, 1, or 2, then it's unlikely that they're going to have a bacterial infection and antibiotics are unnecessary. Unfortunately, this is just kind of like a rule of thumb. It's not a great way of moving forward, and there is a lot of interest in developing rapid diagnostic tests that you could use in primary care, but none of these have actually achieved widespread use with a good evidence base so far. How do you diagnose a sore throat if you do want to engage in a microbiological diagnosis? Well, we take a throat swab, and then when that gets to the lab, it's plated out on blood agar, a kind of agar that contains blood in the substrate there. And what we can see is when we get colonies growing on the blood agar, we get a zone of clearing of the blood in the agar, so-called hemolysis, a breakdown of the red cells. And the particular kind of hemolysis we see in this setting is so-called beta hemolysis, where there's complete breakdown of the blood. And it's said that you can hold the plate up and you can see daylight through it, you can read the newspaper through it because it's the blood has been lysed so completely. This is in contrast to what's called alpha hemolysis, where you get some breakdown of the cells, but you're still left with a reddish, a greenish pigment typically there. Anyway, the other thing we do is that we can then type the organisms. Once we've got these pure colonies growing, we can type them on the basis of their capsular antigen, and commonly this is done using little latex beads that have been coated with antibodies, and you gently rock a suspension of the bacteria and the beads, and you'll get this kind of agglutination, what you can see here. Also there's just a picture of what streptococci look like. They are gram-positive cocci that typically form chains when we see them down the microscope. So just adding a little bit of microbiology to the talk. If we have made a diagnosis of pharyngeal, of streptococcal pharyngitis, then the treatment is with oral penicillin, phenoxymethyl penicillin, for 10 days. And the reason we give this is not primarily to treat the infection that's in front of you. It is to prevent the most severe sequela of streptococcal pharyngitis, which is rheumatic fever. And there is a good evidence base that this treatment does actually work to prevent rheumatic fever. Another important point, though, for you as doctors to realise is that if you get a streptococcal pharyngitis yourself, then you are a risk. You present a risk to patients. And patients who have streptococcal infections in hospital, they have to be isolated because this organism, if it gets into a wound, and can cause very serious wound infections and very rapidly progressive wound infections. And so if you get a bad sore throat, you are justified at staying off work. And particularly if you're doing a surgical job, you have to stay out of the operating theatre because you will put your patients at risk. Other complications, well, you can get an abscess forming next to the tonsil, so-called quinsy or paratonsillar abscess. Some strains of Streptococcus pyogenes have a toxin which gives rise to this infection of scarlet fever. So in addition to having that sore throat, you have this fine raised rash. Feels rather like sandpaper under when you feel it, coarse sandpaper. You often get red cheeks and also redness of the tongue as well in this particular complication. And as I mentioned, the most important sequela is rheumatic fever, but there is also immunological cross-reactions can give rise to glomerulonephritis. And part of the diagnosis of these conditions to show that they are linked to a streptococcal, prior streptococcal infection is measurement of antibody titers. So we measure what we call the anti-streptolysin O titers in the blood of a patient who might present with what could be rheumatic fever or glomerulonephritis. Now this is diphtheria. This is a rare infection and it's unlikely that any of you will see it. There is now only a handful of cases reported in the UK every year, and they are pretty much always imported. This is an acute toxin-mediated disease caused by Corynebacterium diphtheriae, which is a gram-positive aerobic bacillus. And it typically involves the pharynx and the tonsils. It can infect elsewhere. You can actually get cutaneous diphtheria, where cuts and grazes get infected by the organism. But the most typical presentation is like this, where you get infection of the back of the throat, and you get production of this leathery adherent membrane. So diphtheria comes from a Greek word that means leather. And the thing with this is that you get growth of this membrane, and it can extend downwards and can actually become so bulky that it causes respiratory obstruction. And so this is a particularly nasty way for a patient with diphtheria to die, and they would do if you did not actually give the right treatment for this. As I say, it's a rare infection, but I mention it because it is a very serious infection. The other thing is that the toxin that's released by the organism causing diphtheria moves into the circulation and then causes distant effects. So it can damage the heart muscle, and it can damage nerves as well and cause peripheral neuropathy. And this is therefore a medical emergency, and there's an urgent need to get anti-serum against the toxin into the patient as quickly as possible, and also to take a careful look at the airway, and if there's any chance of obstruction, get a tracheostomy done. So this sort of thing that if you ever see it, don't hang around and worry and wonder what to do next. Actually seek expert advice immediately and get on and start treating with erythromycin as quickly as possible. The erythromycin probably doesn't do too much to control the infection because once it's established, but it will prevent shedding of the organism. And we can prevent this. This is prevented by routine childhood vaccination. One interesting question that arises from time to time is how much do we have to booster immunity to diphtheria in adult life? And there have been outbreaks associated with the disease primarily in adults in later life. And this is an interesting question. And the advice I think now is that you should boost adults. And this is something that you as healthcare workers probably also should be undergoing every 10 years. Infectious mononucleosis, otherwise known as glandular fever, is another common, this is, by contrast with diphtheria, this is a common condition that you will see very commonly. It's caused by a virus called Epstein-Barr virus, and it's spread primarily, it's carried in the saliva, and it's spread by kissing. And this is why it is commonly seen in children and in adolescents as they start exchanging saliva with each other. It's got an incubation period of about a month, and the clinical features are quite fairly distinctive in this particular setting. You get fever, malaise, sore throat, but as the name glandular fever suggests, one of the cardinal features is you get this quite pronounced cervical lymphadenopathy. The malaise is actually quite pronounced as well, so these patients will come in feeling really quite sick, fatigued, or almost prostrated by their illness, and it may take them several weeks and sometimes even months for them to get back to their normal feelings of energy and engagement with life. You can, in some cases, get splenomegaly, and there is a risk in these patients of splenic rupture. And I haven't put it on the slide, but one of the things that is we should caution patients about is avoiding any kind of risk of traumatic injury from things like contact sports. Patients shouldn't be playing rugby and so forth for the duration of their illness. Another interesting little feature here is that if you give these patients ampicillin or amoxicillin, they develop a particular characteristic rash that you can see here. And this is a kind of pitfall for the unwary. So if, as a GP, you think, I just give everyone ampicillin when they come in my clinic, they've got a sore throat, give them ampicillin. There will be some patients who you've given this to who have infectious mononucleosis and go on and get a rash. In fact, when I was your age, I used to read the Medical Defence Union's little notes on what cases they dealt with in the previous year, and there was a case that struck in my mind of a law student who developed glandular fever, went to his GP, the GP gave him amoxicillin, and he developed a rash, and what law students have to do, a lot more than doctors, is they have to go and schmooze with all these great and the good in their profession. And this guy was supposed to be going to some black tie event and meeting the worthy people in his own profession, and he couldn't go. And he happened to live with a medical student who said, oh, well, your GP shouldn't have done that. Should have given you penicillin. Even if they did think it was streptococcal infection, should have given you penicillin. And he sued the GP and won a settlement from the GP for this rash that didn't have to happen. Diagnosis is primarily serological antibody testing. You probably come across this term, the monospot test, which is a long-standing test. It's probably been replaced in most settings by a more sophisticated anti-Epstein-Barr virus antibody test, but this is the mainstay of diagnosis. And then management is symptomatic. There are questions sometimes about whether you should give these patients steroids to dampen down the immune response, or whether antivirals can play a role, but none of these things are actually currently recommended on the basis of current evidence. Another set of infections that we see are related to the upper respiratory tract are when the organisms that are in the upper respiratory tract spill over into adjacent compartments. So they can spread into the sinuses, or they can spread into the ear. And when it's typically the same organism. Streptococcus pneumoniae and Haemophilus influenzae are common inhabitants of the upper respiratory tract. And one of the problems we have here is that distinguish between the normal commensals, the normal microbiota, and pathogens in this setting can be quite difficult. but certain strains of these organisms have an enhanced ability to cause disease. They get into to these local compartments and cause fever, pain, dizziness, and if they get into the ear, they can cause deafness. There are quite long guidelines on exactly what to do and how to suspect infection. But if you do expect bacterial infection, then you usually give amoxicillin. Another tendentious issue is when these problems, particularly the otitis media, become chronic in children, whether you should intervene surgically and whether these things called grommets are put in as a way of allowing the ear to drain, the middle ear to drain externally. This is, again, one of those issues that seems to be kind of controversial. It seems they're quite commonly given, but whether the evidence base is good or not is unclear. Another infective emergency, again, this is one like diphtheria, which is rare, but unlike diphtheria, it's become rare in my working lifetime. It used to be a well-recognised problem that you would have come across, but now, because of the introduction of the Hib vaccine, it is now very rare indeed. One of the changes, though, is that this used to be a disease that we saw in children, but because of the impact of vaccination going through the cohorts of children, it is now, if it is seen often in adults rather than in children. And the problem here is, like with diphtheria, you can get an acute respiratory obstruction. The swollen epiglottis can actually just block the respiratory tract. And so these patients, you have to take immediate care of their airways. And one of the things that people say is that if you suspect it, then just don't go in there and start sticking swabs into the throat. Go and have a nose around and look-see. Basically, don't interfere, but immediately send them into hospital and get an anaesthetist to start looking at airway management straight away. Diagnosis, the three things that people say you can see are drooling, dysphagia, and distress in the patient as kind of things that you can see from the end of the bed, if you like. The other thing is, as I say, don't take swabs. This infection is an invasive infection, so the organism getting into the tissues and it spreads into the bloodstream. So you can take blood cultures in this setting and make a diagnosis that way rather than having to take a swab locally. Treatment, cefotaxime or ceftriaxone. And it's important that you isolate the patient because this organism, capture type B, can actually spread to other patients. Pertussis is another nasty infection of the upper respiratory tract, and unfortunately there's a chance you may see this because we have not eradicated this, even though we do have a vaccine for this. It's caused by an organism called Bordetella pertussis, a fastidious gram-negative rod. And the infection has a clear sort of set of stages through which the disease progresses. So it starts off with what we call the catarrhal stage, where it doesn't look that much different from a bad cold or sore throat. But after a couple of weeks, it then worsens and the patient goes through this, what's called the paroxysmal stage. And this is where the infection gets its name, whooping cough, because they have these horrible coughs that make a whooping sound, and the patient will struggle, and this can be quite debilitating and exhausting for the patient. And typically these patients, they have to be nursed in a kind of darkened room and just left on their own. And if you disturb them and in any way stir them up in any way, it can provoke another coughing fit and really be quite unpleasant. And then after that, there is a prolonged convalescence stage where they have lost weight during the acute phase of the illness, and they need to just get back to their normal energy levels and normal life, and they can be debilitated for some time. And there are these sequelae. They can, in severe cases, get brain damage. They certainly risk from weight loss because they're not going to be feeding very well. The coughing can lead to surgical emphysema as well. Fastidious means that it has a requirement for very exacting requirements for growth in the lab. So it doesn't grow overnight on any old medium. You can't just grow it on blood agar overnight. What we have to do is you have to have a special culture medium designed particularly for this organism, and we have to leave the plates up for several days. So it's one of those things where we don't look for it normally, routinely. It requires there to be a clinical suspicion for you, the GP or the person in the A&E, to say, oh, look, I think I might have pertussis here, and can you look for it specially? You can, the other thing, though, that is particular about this is sometimes you do get a lymphocytosis, typically, on the blood picture, but to make a definitive microbiological diagnosis, you have to not sample the back of the throat, the normal back of the throat, the oropharynx, but you have to pass a swab through the nose and sample the nasopharynx to get the best chance of getting a diagnosis here. So again, that's a particular feature where you have to suspect this in the first place clinically. You can give treatment if you know that this is likely to be a whooping cough, or you've got a microbiological diagnosis in the catarrhal stage. Then giving macrolides like erythromycin or clarithromycin may help to mitigate the course of disease. But by the time they've started the whooping, it's too late. Although treatment then still does prevent infectivity. And as I mentioned, you have to just give supportive treatment, try and keep these patients rested and relaxed. And we can prevent this. It is preventable as part of the normal course of DTP vaccines. The other thing is that we have to, in this, and I didn't say it, but I think I mentioned it in passing, but patients who have invasive Haemophilus disease as well, we look for contacts, and we may give prophylactic treatment to those contacts to prevent them from getting infection as well. So now I'm borrowing some slides from Esther, and she has rooted many of her introductions to illnesses in clinical scenarios. So here she's telling us about someone who feels a bit rubbish, 27-year-old woman, who's got this sudden onset of fever and chills, has a dry cough and a runny nose, and a headache, and also has myalgia. Muscles are aching and really feels quite horrible, and just wants to go to bed and lay in bed and sleep. And this is the typical setting of a flu-like illness, and obviously paramount flu-like illness is flu itself, caused by influenza virus. There are other related viruses that can present with similar kinds of flu-like illness. And in fact, the flu-like illness is a very non-specific thing, actually. It's just an effect of all those cytokines being released. And we do see this in many other illnesses. So someone presenting with Ebola or smallpox or whatever will start with a flu-like illness as well. So what about influenza? So this is a disease that comes in yearly epidemics. So we have this seasonal change throughout the year, and we're just starting now the kind of the epidemic period in the winter months. I got a letter from my GP about 3 days ago calling me in to have my flu jab for this coming year. What we see from year to year is a process that's called antigenic drift, where the virus accumulates just occasional point mutations in the protein coding genes, which lead to small-scale changes in the antigenic profile within the virus. And we can typically predict with some degree of accuracy what is coming in the winter, because we can look at what's circulating during the previous year and earlier in the year, and we can come in with vaccines that will still have a good deal of efficacy. What we sometimes see, though, every few years, is a big change in the makeup of the virus, and this is what is termed antigenic shift. And this is where the actual genes and the components of the genome of the virus get shuffled around, and we come up with new combinations of antigens in the various proteins that the virus produces. And typically this is happening not so much in humans, but in other vectors of the virus, other hosts of the virus, birds and pigs. And we end up with totally new antigen types. And you've probably heard over the last decade we've had threats of bird flu and pig flu and swine flu and so forth. The rates of infection typically highest among children, but the disease strikes most severely at the extremes of life, particularly in the elderly and anyone who has other medical conditions that may make them more susceptible. So people who've got chronic lung disease, people who have asthma, these are the people who will have the most severe course of disease. There are two main types of the influenza virus, A and B, and there are many subtypes. And these subtypes, I've mentioned, that undergo this antigenic shift. These are related to the surface antigens, the hemagglutinin and the neuraminidase. And immunity, if you have immunity, it decreases the likelihood of infection in the first place, and if you do get infected, you tend to get less severe disease. But the problem is that there are these many different types circulating around the world over time, and therefore we can't just vaccinate a person once against influenza and protect them for life. This is a continual process, painting the fourth bridge, where every year patients have to be brought in and revaccinated with the current best vaccines that we have. In terms of clinical features, we've already mentioned them, really, that you feel pretty ropey. It's a prostrating illness. There's all this talk about man flu where people say, I can't go into work, I feel a little bit ill, and they're sitting up at home watching daytime TV. Real flu isn't like that. You go to bed, you lie in bed, you have a restless sleep, and you just feel rubbish. One of the complications, there are various complications that are life-threatening with flu. You can get a viral pneumonia, and the most threatening thing is perhaps of a viral superinfection. So during the great pandemic flu epidemic of 1918, the patients would typically be dying from this bacterial superinfection with the pneumococcus, Streptococcus pneumoniae. And it's clear that there is a synergy between these two pathogens, influenza infection paving the way for subsequent bacterial infection. Yes? What I mean is that you've already got one infection with one organism, and then you get a second infection on top of that. So the first infection makes you more susceptible, lays the way open for that second infection. So it doesn't mean that it's a much worse infection, it just means it's a second infection on top of the other one. And the risks here are greatest, as I mentioned before, among the elderly, and there's this thing called the CIRA score that can be used to work out who's at greatest risk and who actually perhaps needs to go into hospital. I've given you all the recommendations here, but things like confusion, high urea, high respiratory rate, low blood pressure, and having an age of over 65 years. Each of these things, if you've got two of those points, then you're in a high-risk situation and the patient needs to be hospitalised. We offer vaccination treatment to at-risk groups, so everyone over 65 and people with these other complications, some of which I've already mentioned. Pregnancy actually predisposes you also to some of the more severe complications of influenza. One of the interesting questions is, what do we do with healthcare staff, and when are they vaccinated? And it is recognised that it's worth considering if there's particularly a pandemic going on to vaccinate healthcare staff, because obviously you do not want those at the front line of in the medical service all going off with flu, so this is an interesting point. We can treat patients with antivirals, neuraminidase inhibitors. This has to start within 48 hours of onset for it to be worthwhile, and this is not offered to everyone. It's offered only to these at-risk groups. And we can vaccinate as well, and that's generally offered to various at-risk groups in the population. Right, I have to move a bit faster. I'm running out of time, aren't I? So let's think about the next scenario. We've got a baby, 5 months old, fully immunised, had an elective cesarean, 2 older siblings that are both healthy, being bottle-fed, being breastfed for a couple of months now, bottle-fed, and presents with this one-day history of temperature, cough, wheeze, following a snotty nose. And when you examine, you find that the respiratory rate is 65, SATs are 91%. Got nasal flaring, and here's a picture of intercostal recession. This is actually from a premature baby, but it shows the feature you would see in this situation. Widespread wheeze, and so this patient has been admitted through casualty to the paediatric service. What are we seeing here? Well, we're seeing the condition of bronchiolitis, inflammation of bronchioles. It's a common problem in childhood. And about 70% of these cases are caused by respiratory syncytial virus, or RSV, as it's often known in the jargon. And again, this, like influenza, it comes and goes according to the time of year, particularly causing epidemics in the winter months. And by the time you get to 2 years old, 80% of individuals will have had this infection or developed antibodies. So as with many infections, those that present with obvious clinical infection are the tip of the iceberg. Lots of people will get infected subclinically or just have a very short, inconsequential illness. But when it does present with severe clinical symptoms, you get these cold-like symptoms that progress to this harsh barking, cough, worse at night when agitated. Patients are usually distressed, and the parents are starting to get distressed as well. Poor feeding, lethargy, and you get wheeze and apnea in the worst cases, and you can progress to respiratory obstruction, and the patients become exhausted as well. And so to get a laboratory diagnosis, we need a nasopharyngeal aspirate, and then you can look for signs of the virus using immunofluorescence or PCR. Most of these cases, all you need is supportive management, and most of them are managed in the community, and they recover within a week to 10 days. So just making sure that the fluids are okay, the nutrition, keeping the temperature down. And they may require admission if there are markers of severity, and the details of when to make that decision I've provided in the notes that I've linked to. They may require oxygen, CPAP, they may require NG feeding. Only a small minority actually need to go on a ventilator. But you also have to remember infection control is an issue as well, because this is a highly infectious condition. There is a license available for using an antiviral, nebulized ribavirin, but the evidence base for its use is not strong, and therefore it's not recommended as routine. It might get used in some cases, but it's not part of the routine thing. And we mentioned already prevention through hygiene. There have been attempts to develop a vaccine, and the vaccine was licensed for a short time, but it actually turned out that the vaccine made the disease worse. I think there is great hope that there will one day be a vaccine, but we don't have one yet. What we do have, though, is an antibody treatment that appears to work. Antibody treatment, passive immunization that can be given. So in patients who are particularly high risk, particularly if there's, say, an outbreak in a family or a neonatal unit, you can give this particular antibody. And most patients do make a full recovery. Some of them will wheeze for a long time afterwards, and the mortality is relatively low, but is still appreciable. It is there. Okay, our next patient, 68-year-old woman, complains of this horrible, mucky sputum there. Nice start today to have to see that in front of you. She's got shortness of breath on climbing stairs. She smoked for many years, although she's an ex-smoker now. And what she's experiencing is an acute exacerbation of COPD. And these exacerbations are characterised by having 2 out of the 3. They produce more sputum than usual. The sputum they produce is purulent, it's mucky and pus-filled, and they become more breathless. And most of these exacerbations are so-called infective. And viruses do account for a significant number of these, and some of them are bacterial. Probably more than half of them are actually bacterial. And there's a package of interventions. So we have to obviously look at the patient's respiratory condition and the airways with bronchodilators and steroids to help with the flow through the airways. But we do also give antibiotics. Again, this is one of those areas where they probably do help, but it's quite hard in some cases to tie up the microbiology in a neat way. Because as I've mentioned before, things like Haemophilus influenzae and Streptococcus pneumoniae are normal inhabitants of the respiratory tract, and just growing them doesn't necessarily mean that they're contributing to the disease process. But what we typically recommend are things like amoxicillin or doxycycline. Patients with COPD are offered influenza and pneumococcal vaccination to prevent these exacerbations that are due to those particular organisms, but we don't actually, clearly there isn't an evidence base for prophylactic use of antibiotics. It's kind of more of the same, another disgusting cough producing this horrible sputum. A 59-year-old woman, never smoked. I don't know if Esther actually made these scenarios up or whether she's drawn them from her own clinical experience. They all, to me, seem perfectly plausible scenarios. She's had 8 courses of antibiotics over the past 2 years for chest infection. She's got shortness of breath on mild exertion, and she's been hospitalised with pneumonia 5 years ago. But apart from that, nothing much else going on. And what turns out that she has got is a condition known as bronchiectasis, which is much more common in females rather than males. It may present at any age, but does tend to present in the highest prevalence in the older women. A lot of the time it just comes out of the blue sky, and we don't know what the reason is that it's developed. But it can sometimes follow on from infections, and it can follow in various genetic disorders, antibody deficiencies, alpha-1 antitrypsin deficiency. It is also a problem in cystic fibrosis, but we're not going to say anything about cystic fibrosis today because that is covered elsewhere in your course and is a whole subject in its own right. And now in recent years, with the ready availability of CT scans, this has now become a radiological diagnosis. So the patients will have a CT scan, and this will show thickening of the bronchial wall and dilatation, as you can see in this CT here. Again, as with exacerbations of COPD, we often grow things from the sputum, and we start with empirical treatment, and then we use antibiotics effective against the organisms that are cultured, even though there are uncertainties about the causal role here. And I've just grabbed here, done a screen grab, it's not as readable as it might be, of the advice that is given in one of the guidance documents from the British Thoracic Society there. Okay, we got here a cough that's getting worse. Here we've got a young person, 34-year-old, who's got a bit of mild asthma, is getting worsening symptoms over the last 5 days, harsh cough, brownish sputum. And then when you take a chest, and then there's pain in the chest and shortness of breath. And when you look, you get these clinical signs here, particularly with poor air entry, the right middle lobe, and on the chest x-ray you can see here this lobar consolidation. So this is the typical picture of lobar pneumonia caused by Streptococcus pneumoniae or pneumococcal pneumonia. And here, as I mentioned earlier with epiglottitis, here we have an infection that is not just localized but is spilling out into the blood. So you can make a diagnosis by taking sputum, but in these patients also, if you take blood cultures, you will often grow the organism from the blood as well. And this is caused by Streptococcus pneumoniae, otherwise known as the pneumococcus. And this can be seen on the gram stain in the sputum in large numbers, although perhaps not as a reliable way of diagnosing infection. But when we grow it on blood agar, it has particular characteristic colonial morphology, so-called draftsman's colonies with this sunken middle, and they're soluble in bile, and they're sensitive to a particular antibiotic called option. So this allows us to identify the pneumococcus in the lab quite easily. Treatment, traditionally, this used to be always responsive to benzyl penicillin, but now we're seeing the emergence of resistance, and so we give broader spectrum agents empirically when we suspect this infection now. There is a vaccine available against the pneumococcus. Again, this is like flu. This is an organism that has many, many different serological types that are distinctive, with different capsules being produced with different antigenic profiles. And so there isn't just one vaccine that we can give once. We have to give this polyvalent vaccine that's got a mixture of the most common capsular serotypes. And this is offered to those at risk, the ones listed here. How are we doing? Nearly finished. Atypical pneumonia is where you get clearly a pneumonic picture. Someone's got a pneumonia, but they don't have that lobar consolidation, and this is often seen with what we might call atypical bacteria, things that don't grow particularly well in the lab, or in some cases don't grow at all if we don't take extraordinary steps. The mycoplasma, chlamydia, what used to be called the chlamydia pneumoniae incitici group, now called chlamydophila. And then we've also got Legionella causing Legionnaire's disease, which can cause a mild kind of flu-like illness known as Pontiac fever, but in severe cases causes a prostrating pneumonia called Legionnaire's disease with a relatively high mortality rate. And so if you suspect these atypicals, we can do a microbiological diagnosis using antigen detection and culture and serology and antigen detection for other atypicals apart from Legionella. Okay, so in terms of management of pneumonia in adults, there are local guidelines, and we need to cover pneumococcus, Haemophilus sometimes as well, particularly if we've got patients with underlying things like COPD and the atypicals, and these are typically what we would give, but there are detailed guidelines if you want them. We sometimes get localized purulent infection in the respiratory tract. We can get infection, a localization of pus in the pleural cavity, that's called pleural empyema, and we can get lung abscess. And these have a range of different microbial causes, and the most important thing is to get surgical drainage straight away, and then give broad spectrum antibiotics tailored to the microbiology in question. And there are various causes, as you can see there, that may lead to this. Also worth mentioning in passing, some of you are going to be working in hospital practice, that we do get pneumonia in hospitalised patients that's acquired in hospital and has particular characteristic features in the setting of complex and prolonged illness. And we have these nasty multi-drug resistant hospital pathogens that are selected for by antibiotic use. So you will see this in the critical care patient in the intensive care unit. You'll get these kind of infections that you would never see out there in the community. I should say carbapenem. It's got the P and the B the wrong way around. This is what they recommend at UHCW, that you give these patients coamoxiclav, gentamicin, or piperacillin and tazobactam plus gentamicin. Right, I'm just going to finish now in the last few minutes just to give you a recap, because I know you've had stuff on this before, but just to remind you, how do we diagnose infection? We start with clinical diagnosis, with sticking your stethoscope on the patient and listening to the chest. Do all these non-microbiological investigations. Obviously, radiology is very important here, and also hematology and biochemistry. But in terms of the way we approach microbiological diagnosis, the kind of lazy house office just scribbles on the form MCNS, and MCNS stands for microscopy, culture, and sensitivities. So we can stain the sample that you send us, we can culture organisms from it, and obtain them in pure culture, growing as individual colonies, which you can then pick and propagate, and then investigate biochemically and so forth. And then we can do sensitivity testing, where we can actually work out what antibiotics they are susceptible to. And in addition to that, we have other modalities like CIRA diagnosis and use of DNA sequencing technologies. When we're looking at sputum, microscopy is not particularly informative. The one case where it is useful is in TB, where we can use this particular form of staining for what we call acid-fast bacilli, where we apply the stain and then we try and leach it out with acid. You may have heard of, I should say, Ziehl-Neelsen or auramine staining. These are two different staining approaches. So at the top there you've got the ZN stain, and you can see that pinkish rod there, which is an acid-fast bacillus. You can also use microscopy in immunocompromised patients to look for this relatively rare cause of lung infection, pneumocystis. We can grow things from sputum, but it's quite hard to interpret the results, as I mentioned several times now, that there's an overlap between the normal microbiota and pathogens, and the pathogens are often specific pathogenic clones of that normal microbiota. So you have to look at this carefully. If you've got a heavy, pure growth of one organism, that may give you a clue, but you also have to look at the patient and interpret the results. So if the patient is sitting up in bed and watching telly, you can take a different approach than if they are severely ill in bed, requiring respiratory support, blood gases going off, and so forth. There's a list of things that we don't culture routinely, so you have to have the clinical suspicion to ask for them. CIRA diagnosis, we can look for antigens, and we can also detect an antibody response. Looking for antigens, we can look straight away, and it works quickly. Obviously, waiting for an antibody response takes some time, and it's usually after the event. But this sometimes can be useful. If we're looking at, say, is there a Legionella outbreak going on or something like that, we can go back and say, oh yeah, that patient had a fever a couple of weeks ago, they've got a rising titer, they had Legionnaire's disease. And in TB, there's interest in cell-mediated immunity as a diagnostic modality, these so-called IGRA tests that can be used. Nucleic acids, we can detect the DNA or RNA directly in samples, and in my own research group, we've been interested in actually directly sequencing DNA from samples as a way of making a diagnosis. And then finally, in the last couple of slides, just to reinforce the fact that you have to manage infection correctly. So treating the patient when they present, say, in A&E, looking at airway, breathing, circulation, disability, exposure, and sepsis 6. The sepsis 6 there, looking at attention to oxygen levels, blood cultures, intravenous antibiotics, blood count, IV fluids, and looking at urine output, measuring all those things and doing all those things when you suspect sepsis. Key point is that it's best for you to take cultures first before you give antibiotics, because even a single dose of antibiotics can be enough to effectively sterilise those cultures, those samples when they come to the lab, and make it much harder for us to make a diagnosis. Obviously, in the very acute case, a very severe patient, you may not be able to do that, and you may need to get antibiotics in straight away. But if you can, take the cultures first. And then in terms of using antibiotics, there's this idea of using, start smart, then focus, actually. Use appropriate empirical antibiotics, look at local guidelines. Also, you don't have to always use drugs, antibiotics. You can drain pus. If there's foreign bodies, get it out. If there's dead tissue, cut it out. All of these are important. And if you are using antibiotics, apply proper stewardship, using the right drug, the right dose, at the right time. And there usually are local policies in addition to these national guidelines, and you have to tailor your treatment to be effective against the likely or known pathogen, and you have to be safe. And that's just a reminder of the spectrum of antibiotics that we use. And I've now come to the end. So just to remind you what we're hoping you will have learnt during this, that you should be able to define these common terms and define the common syndromes, be familiar with some of the common organisms, and apply the principles of diagnosis and management to these infections. That's me finished. I'm now happy to take any questions. If you have any, if you want more information, there are the guidelines available from the British Thoracic Society, available online, extensive guidelines. I don't want you to go and look at that and then panic. Just look at the summaries if you're interested. If you want to get more, if you want to just recap your information, your knowledge about microbiology, I put a link there to a couple of introductory lectures that I gave with Esther a couple of years ago that are on YouTube. You can look at my whole YouTube channel if you like. Also there is a link there, that one that says 2016. A few of the papers that I've picked up as I've been preparing this lecture, I've just chucked them in a folder. So if you want to pick them up yourselves and read them, it just saves you having to go and drag them off the internet. Good, that's me finished. Thank you very much.